Welcome to the Massachusetts General Hospital Community Forum Friday webinar series. My name is Katie Brandt. I'm the Director of Caregiver Support Services and Public Relations, and I'll be your host, your moderator for today's session. The title for today's session is Discussing Intimacy and Sexuality After a Diagnosis of Dementia, a conversation with Dr. Jennifer Pilcher. We wanted to bring this important topic to our webinar series today because it acknowledges personhood and dignity at every stage of life lived with a diagnosis. We hope to demystify this topic and present information in a way that's comfortable and also informative. We want you to know that sexuality and sexual relationships, we acknowledge that they happen between lots of different people. And this session is about sexuality in general. We may use heteronormative examples, but the concepts will apply across the LGBTQIA+ spectrum. This is a live session today, so I'm encouraging all attendees to enter questions into our Q&A. After Dr. Pilcher presents, I'll moderate that Q&A, and she will be able to answer questions live. This is a great opportunity, and we want to take advantage of it. So now it is my privilege to introduce Dr. Jennifer Pilcher. Dr. Pilcher was awarded her doctoral degree in gerontology from UMass in Boston in 2005. Her professional experience has focused primarily on care and housing arrangements for elders with Alzheimer's disease and related dementias, including policy and even fundraising work for the Alzheimer's Association. She's had a career with lots of experience working with people living with dementia and their families. And in 2018, Dr. Pilcher founded Clear Guidance in order to return to her passion of working directly with families living with young onset dementias. I want to say, from working with Dr. Pilcher as a community expert with many of the families in our program in the MGH FTD unit, she is a compassionate expert, and we're thrilled to have her as a part of our session. Dr. Pilcher, welcome.
Thank you so much, Katie. I'm going to go ahead and share my screen here as I have some slides I would like to share. Okay. So thank you all for being here today, and we're really hoping to demystify a lot of the discussion around this. We know that this is largely a taboo subject that many of us have been discouraged from talking about over our lives, and I'm hoping that we can open this up for a more open discussion today. If you had asked me 20 years ago when I got into the field of dementia if I would be presenting on sexuality and intimacy, I wouldn't have believed you. However, over the years, I have come to appreciate how difficult this subject is to discuss and acknowledge, and how important it can be for relationships where one or both partners have a cognitive impairment. So I encourage you, whether you're a spouse, a partner, a sibling, an adult child, a family member, or a professional care provider, to ask your questions and share your challenges if you're open to it. And I hope I can be helpful in shedding some light on this topic. Okay. We know that this is something that is confidential, and if you don't feel comfortable sharing, that's okay too. I'm going to try to walk us through many of the challenges that people face. So there are three themes we're going to talk about today. Oh, I'm sorry. Excuse me one second, Katie. I think this is the wrong version. Hold on one second.
That is no problem at all,
I
Dr.
just want to
Pilcher.
stop sharing and bring up the next. I think I have the wrong version of the slides.
Yeah, we can wait while you do that. And it's a good opportunity, I think, for people to sort of settle in to the topic. As you know, I really appreciated what you just said about we know that this is a confidential and private topic, but you're here to walk us through it.
Yeah. Can
Oh,
Felicia help me stop sharing for a second so I can bring up the other version of the slides?
sure.
Thanks.
Felicia, if you're able, perfect. Take your time.
Thank you. Yeah. Okay. I see the problem.
Many of you know that in my role as Director of Caregiver Support Services, I've had the opportunity to work in clinic with families, and I've always felt humbled by the compassionate nature of questions related to this topic, and just really have wanted to bring more information about it so that we could talk about it in an educated and informed way.
Thank you. All right. I think we're getting there. Just give me 1 second. What I need to do is this. I apologize. I don't know why this is so difficult.
Well,
One-
we can even use it as an analogy for the topic that sometimes you need a couple of chances to get it right.
Exactly. All right. Here we are.
I'm
Okay.
sure you will.
There we go. Share screen. Okay. Here we go. All right. So there are three themes we're going to talk about today. The first theme is about intimacy between a couple after they've had a diagnosis. The
Jennifer,
second theme
Dr. Pilcher,
is,
could you press
yes,
the
yep, thank you.
slideshow version?
The second theme is about intimacy and relationships between individuals that are living with a cognitive impairment. And then the third theme we're going to discuss is hypersexuality. We're going to briefly touch on this as it is a rare issue in sexuality with people with dementia, but something we do want to talk about briefly. We're going to frame this discussion today from three perspectives: from the perspective of the person with dementia, from the perspective of the care partner, and from the perspective of the community provider. Um, You'll notice that I've used images here of younger people, and I did that intentionally, in part to raise awareness that dementia is something that affects a lot of older people, but it's also something that affects younger people, particularly people with FTD. A lot of them are younger, and so I've used images to relate to that real fact for a lot of folks that I'm sure will be watching this. There are quite a few things that both persons with the illness and their care partners have in common. For example, a diagnosis of dementia impacts all areas of the marital experience or the partner experience, including the most intimate ones. The goal of any intimate interaction is to express love for our partner. And for many people, sexual intimacy is at least part of the way they do this. So, for a lot of folks, both the person with the illness and the care partner have a desire for a continued connection. They have a need for love and emotional validation. They're both dealing with the grief of the diagnosis, but also of the potential loss of this side of their relationship. The diagnosis has often caused a big upheaval in the relationship, and both have a fear of rejection that is really a foundational part of who we are as humans, that fear that we will approach someone we care about and be rejected. So it's important to keep these things in our mind as we think about the different perspectives, how much there is overlap in the experience as well. For both the person with dementia and the care partner, it's important to remember that this is not personal, the changes that occur with a diagnosis, but a symptom of an illness which both of you in a partnership are experiencing, but experiencing differently. That's why it's important for us to look closely at what is happening for both people as part of the couple and try to understand both perspectives. Cognitive decline can have different effects on sexual interest, desire, and behavior. Some people with cognitive impairment will have diminished sexual interest or apathy, while others will show increased interest and less sexual inhibition. For those who do maintain an interest in sexual activity, some of the reasons that may be is for people living with dementia, it remains something they can do and give to their partner when they can no longer provide things like income, making decisions, or even helping around the house the way that they used to. Remaining sexually active provides one of the few ways they can maintain their identity as a spouse or a partner and provide something that's valuable to their partner. On the other hand, the causes of a loss of interest in intimacy may occur for several reasons. First of all, the disease can have quite an impact on your self-confidence, your self-concept, and your self-esteem. Many people who are experiencing dementia feel anger or disappointment with themselves and with the situation. They feel anger and disappointment with their spouse for the inability to handle the changes in their behavior or in their function. Um, for especially people with FTD, the connection to emotion or empathy can be diminished or even absent. Um, some people with dementia feel that the caregiver is not emotionally available to them anymore as they're busy or distracted with the additional responsibility they've taken on as a result of the diagnosis. It's also true that sexual dysfunction can occur due to cognitive sequencing problems or physical limitations, or even loss of sensation due to the illness. And lastly, I think what is really important to discuss is that depression is a common side effect of dementia. And the primary effect of depression on sexuality is reduced sexual interest or desire. So all of these things can contribute. It's also true, I had a client who was in a marriage where they had a very intimate relationship. And as her disease progressed, she became feeling that it was inappropriate for them to be participating in this kind of activity. And so her attitude changed about what behavior was appropriate. And that caused a loss or a diminished interest in intimacy or sexual activity. For the care partners, many of them want to maintain an intimate relationship with their partner because they find sexual intimacy to be a source of support, reassurance, and a means of coping with what can be a devastating diagnosis. On the other hand, some care partners will also feel a diminished interest in having a sexual or intimate relationship with their partner. In part, this can be caused by the upheaval in the relationship and the change in the role that the care partner is feeling, or even a role reversal for them. And this can cause them to feel disconnected from the person with dementia. It's also true that caregiving is exhausting. And so the care partner may just be too tired at the end of the day to make this a priority in their relationship. It's also true that there can be concerns when hygiene is not as good as it may have been prior to the diagnosis, and the experience is not the same for the care partner as it used to be. It may be that the caregiver is feeling guilt about their lack of interest in having intimacy with the person with the disease, and that can lead to further lack of interest. It's also true in many of the studies that I've read that there's a concern, particularly among male partners, about consent and whether they continue to have consent as the disease progresses. There's a very interesting study. It's an older study that was done in 2009, and it looked at two groups of couples. well, it looked at a group of couples, and the result of the study was that they broke them into two groups of people. And so a lot of these couples that were coming to this study were experiencing the kinds of concerns that we've described just prior to this, in terms of the concerns of the person with the illness and the concerns of the care partner. What they found was that these couples broke into two distinct groups. Group one were couples that had less sexual intimacy but had grown closer on other levels and had deepened their relationship. The other group was a group that had limited feelings of intimacy or sexual satisfaction and were frustrated and disappointed in their relationship. What's interesting is the difference between these two groups when they looked at them side by side was that the group that was able to enhance their relationship even through the process of dementia had a couple of interesting characteristics of their relationship. First of all, the care partners and the person with the illness had the ability and the motivation to utilize emotional support. They also had been very creative about how they had been intimate with each other and had to think outside of the box about that. And we're going to talk more about that in a minute. And the other interesting finding was that they found that the group that ended up having a deepened relationship had more communication between the partners. Now, we know that this is difficult when you're having a conversation about such a sensitive topic. The conversation really has to be non-blaming, non-judgmental, and very careful not to affect either of the couple's feelings of self-esteem or to damage the relationship. But in fact, in group two, what they found was that the couples really didn't know how each other were feeling about intimate and sexual behavior. And so the more they talked about it, the better off they were. So what does all this teach us about what we can do when we're finding ourselves struggling as either a care partner or a person with the illness? So, like dealing with all the other aspects of the disease, it's really important for care partners to employ strategies like flexibility, humor, and acceptance of the diagnosis. I think this study has really pointed to the importance of family and emotional support for people that are going through this. It's also important for the couple to develop and draw upon other levels of the relationship. So the psychological, spiritual, and emotional connection that you have. It's important for you to point out for yourself and your partner the positives of your relationship. And sometimes getting a diagnosis like this gives us the appreciation of the passage of time and focuses us on really paying attention to the present moment. This can be a gift and something that you can utilize in your relationship. Also important to recognize the small gestures and expressions of gratitude that both of you can have for one another. And that certainly is a very important part of not only continuing to maintain your relationship, but finding other ways to be intimate. Some other suggestions, practical suggestions of things you might do. Focusing on shared values and on your commitment to each other. Reliving memories, looking at photographs or watching videos are very important ways to focus back on these values and commitment to each other. There are certainly lots of other ways to engage in intimate activities, dancing, cuddling, kissing, hugging, kinds of massage. And I know that sometimes if you're a care partner that is not wanting to invite sexual activity, you might shy away from things like this, thinking this will only give the message that there's more to come or encourage this kind of interaction, when in fact, really what the person is looking for in a lot of situations is the emotional connection and the feeling of connectedness. And so sometimes doing these other kinds of intimate activities can fulfill that feeling for emotional connection, and may mean that it doesn't go on to other behavior. For hygiene concerns, and certainly this is something that I have heard in the past from care partners, are concerns that they have. I have encouraged our clients to work bathing or showering into an intimate setting. One person that Katie and I both admire is Paul Rea, who's one of the leading experts in this area on caregiving and dementia, says to use the yes but first approach. So in this case, you would say, yes, I would like to engage in this activity with you, but first let's take a shower together. So you're not saying no, but you are giving another option for how you might work that into the scenario, which will hopefully resolve the issue of hygiene concerns. This is also an important thing to talk to your medical provider about. I know a lot of people are nervous about talking to medical providers because they think it's embarrassing, or they think that the provider doesn't have time to discuss these things. But I would encourage you to do so because I think it is a really important thing to talk through, particularly if there are hygiene concerns. There's also sort of a new language out there that a lot of young people are talking about, which is called love languages. And I've given you here the website that I would encourage you to visit. I certainly, these are tools. I certainly think this is not a prescription, but it's more information and another tool you might use to think about what are the other ways that we express our affection and our love for each other, and how can we go about doing that. And this website, and there's a book as well that goes along with it, is more specific about what's the way that you personally need love to be expressed, what's the most important part to you, and trying to think about what's the most important part to your partner, and how do those things match up, and how can you utilize some of these tools to increase and deepen your relationship, the comfort in talking about other kinds of intimacy that you might develop. Okay, so we're going to talk about also intimacy between folks with dementia, or intimacy and sexual behavior that happens in the community. And often this involves community care providers. What's important to mention is that placement does not automatically end sexual connections for couples. And residents and their partners have a right to seek out and engage in sexual expression, and facilities should be giving them the opportunity to do that in a private space to do it in. Providers need to recognize the need for autonomy and personhood, and this being part of that, the right to choose for a person with dementia to continue to engage in sexual behavior, and also the desire for continued connection for not only couples but also individuals. And this needs to extend to relationships that might occur between residents at a facility. What are the barriers to having this be something that is widely accepted in community settings? Well, in these settings that are largely designed to meet the needs of older adults, this discussion is still largely taboo. This is caused by the intersection of some common beliefs, one of which is that sex is for the young, and the other is that sex is for the cognitively intact. So therefore, many healthcare providers have limited knowledge of sexual and intimate expression in later life. And so we need to provide training opportunities for these providers to learn how to provide opportunities for couples to engage in this kind of intimate behavior. The provider has concerns about consent and about safety, and we're going to talk about that a little bit more in detail. And of course, they have an ethical dilemma. There's a tension between respecting and supporting the autonomy of the resident to engage in sexual or intimate activities of their choosing, while also protecting the resident and maybe other residents from potential harm. So this causes a real tension. One last thing that can cause a tension in this kind of situation is that you have two families that may have different beliefs about whether or not this should be allowed. So that also causes an issue for some of these providers. We have a case study here that we would like to walk you through that I think is very poignant in terms of pointing out the way that this can occur in a community setting, and wanting to bring attention to that so that people can understand the reality of how this occurs. Katie, I am unable to read the slide because of other things that are in the way. Would you be willing to just read the case study for me? You're muted.
Of course, I took off my camera, but not my microphone. So I'm going to read the case study. Bill is a 72-year-old man who is living with a diagnosis of Alzheimer's disease and has been a resident in an assisted living memory community for the past 6 years. Bill has a shared room space in the community, but is not currently living with a roommate. Bill is known in the community to be friendly with staff and other residents, and he often likes to joke and tease the staff. Bill also values a romantic connection with a female partner and has had several romantic relationships with different female residents over the past 6 years. The connection shared with each woman has included holding hands and enjoying each other's company during group meal times and for group activities. Bill's relationships have also included private time for intimate activities that included nudity and sexual activity.
Wonderful. Thank you, Katie. So I think this is a great example of the reality of what happens in these community settings and what providers are faced with. And certainly, it is very important that our residents with dementia are given the opportunity to explore this kind of expression. But what does a facility need to do? What does a community provider need to do to make sure that they can resolve these issues of consent and safety? And I think just to add on to this, I know that as this is a real story, and as this story has continued, there have been some concerns about Bill and his partner and the safety of their engaging in sexual activities. And so that's an important part for the facility to look at as well. So I'd like to walk you through some of the ways that community partners can look at situations like this and identify. And hopefully this information, if you are a community partner watching this, will help you to think about it. If you're a family member that has a person inside of a community that you're facing this kind of a scenario with, this will help to give information to you and also to the community about ways we might look at this. So we must resolve the issue of consent and safety. This is really important for the community provider to do. There are some good models out there that give good demonstration about what should be examined in this kind of a situation. So there's something called the SCEA model, the Lichtenberg and Strzepak model from 1990, and there's also the ABA and APA Handbook of Older Adults with Diminished Capacity that has a great discussion on this, and many other studies. So what I have done here is to try to summarize all of what we know out there into bite-sized pieces that are understandable, whether you're in a couple that's living in your own home or whether you're someone who is living in a community. Providers have reasonable concern about lack of consent, and the truth is that there's a lack of specific legal and clinical standards to guide the assessment of whether a person with cognitive impairment retains the right to make sexual decisions. So several models have been looked at, and I've sort of boiled them down to how do we look at consent? How do we make this decision? So there are sort of four basic areas of information here. Does the person possess the knowledge to make a decision? Do they have basic knowledge of sexual activities and the appropriate times and places for sexual activities to take place? Does the person demonstrate voluntariness or choice, the ability to make the decision without coercion? And would they have the ability to take self-protective measures against coercion while they were making a decision? Does the person have a reasonable understanding of the consequences of sexual behavior? And does the person have the skills to keep them safe during sexual or intimate activity? The bottom line is, if these things can be examined and resolved, if the person is able to consent, the provider is obligated to find a way for this activity to safely take place. So first of all, we have to look at the issue of consent, and I've given you some ways of thinking about consent and how do you analyze whether someone can consent or not. There also ought to be a full assessment process looking at this person holistically. And here are some of the things that community providers might look at. It should be an interdisciplinary process that includes the family and the person with dementia, or if there are two families involved, two families and two people with dementia. We need to look at the medical records for this person to determine if there are any conditions that would affect sexual functioning, if there are medications that could affect cognitive or physical safety, particularly medications that have a sedating effect, and if there are elements of functional status that could present a risk while engaging in the sexual or intimate activities. We need to do a clinical interview of the person with dementia. We need to look at their medical, psychological, and social history. We need to look at their functional status. We need to look at their relationship history. And we need to explore how they're feeling about this and what their wishes are for their relationship with the person that they desire to have intimate activities with. We need to do interviews with family members, guardians, and staff members at a community. And we need to have had some kind of neuropsychological testing or the mini mental status exam or the MOCA exam. And people might say, well, what does that have to do with all of this? And I think why this is important is that it will provide insight into the ability of a person to understand, reason, and provide voluntary consent. And so what are we looking at in the neuropsychological testing? We're looking at executive function and problem solving. We're looking at planning and judgment. We're looking at memory, semantic memory, episodic memory, procedural memory. So to illustrate this a little bit, a person needs an understanding of sexual situations. They need attention, and they need semantic memory for basic information about sexual behavior. They need episodic memory for memories of previous sexual experiences that are going to lend context to this. They need procedural memory for disease prevention strategies, for example. And they need executive functioning to understand the motivations of their potential partner. So once all of this information is collected, then the community needs to have a risk benefit discussion with their interdisciplinary team. They need to formulate an action plan that's consistent with safety concerns that might exist. And they need to formulate a plan for constantly assessing the additional risk that may come as the disease progresses. I have read in several studies that some of these community providers will use a psychologist to do this, or they may feel they have someone on staff that can do this kind of an analysis. And I am happy to report that I think a very similar process to this was used in our case study of Bill, and that the facility was, with a lot of guidance and family cooperation, able to come to a situation where they were able to formulate a plan that allowed for safety concerns and monitoring of safety concerns, and that they had evaluated consent and the feelings of the two residents that were involved in this scenario. So I think what they did matches up really well with what we know. But not all facilities are able to do that or have the knowledge and the information. So we need to continue to educate and bring these strategies forward for community providers. I just wanted to touch briefly on hypersexuality, as I know this is an issue for some folks, particularly folks with frontotemporal lobe dementia, who have issues with their frontal lobe. One of Katie and my favorite people in the world, Dr. Dickerson, uses the phrase that often people with FTD or with frontal lobe damage have all gas and no brakes, right? And so that inhibition that may have been there before is not there. That impulse control that was there before is not there. So we're left with just the impulses. In my mind, I see this as being a more behavioral issue than it is a sexual issue. And I think when you look at what's out there, it's still a relatively rare symptom that people are dealing with. But when you are dealing with it, it's really difficult. It's important to talk with your medical provider about this, especially because there could be medical or pharmacological reasons for this. There are actually medications that can cause this symptom. And then we also want to look at the environmental triggers, whether this is at home or whether this is in a community. What is it in the community that's suggesting or triggering this kind of behavior, and how can we change that? And how can we normalize these feelings so that everybody can understand and get on the same page about how we handle it? I think this is really important, and I'll leave you with this thought. The onset of illness does not erase sexuality, but rather alters the way in which love is given and received. And I think I couldn't say it better than they did in this study. And I hope that you will come away from this with ideas about ways that you can continue to have intimacy and sexual activity in your relationships, and to demystify all of this for ourselves, but also for the community providers that we work with every day. So that's the end of my formal presentation, and I would love to hear questions or thoughts on that.
Dr. Pilcher, wow, what a tour de force that was. Thank you. Thank you. I think that, well, first of all, I want to say I had the privilege of workshopping this presentation with you, and both in our time together planning And today in your presentation, what comes forward so eloquently is this idea of love, connection, and belonging.
Right.
Yeah. And I think that for me, when we're talking about this topic, and I think about the couples, the families that I've worked with around these issues, really at the core, that's what rises to the top. It's about the feelings, not just connecting through those intimate experiences, but all the feelings around, I don't know how to talk with my loved one about this anymore. I don't want to feel rejected. I don't want to be rejecting. I was wondering, to start our, discussion time, could you talk a little bit about how do you navigate communication challenges in this domain?
Yeah. And I think this is something we work on all the time with our clients, because communication is hard in general, and different, needs to be specific depending on what kind of a diagnosis you're dealing with and what kind of symptoms the person is experiencing. So, if language, for example, is a barrier, that adds another element of difficulty to communicating about this. And I think I would encourage anyone who's feeling like this is a difficult thing to communicate about to get a third party involved to help facilitate the conversation, because sometimes it's easier for a third party to open the discussion in a way that is looking at everybody's feelings rather than one person in the couple imposing the conversation on another. But I think, as I said earlier in the presentation, these are important discussions to have in your relationship. It's important for it to be in a non judgmental, non blaming way. So it's very important to approach it from a we perspective. What do we want for our relationship? And to start talking about the relationship in general, and this being one part of the relationship. But if the conversation is about the relationship and what you want the relationship to be, then this is just one aspect of the relationship, but not the entire conversation. So I think setting the context of the discussion is really important too. So I hope that's helpful.
I think it is. And I really liked your idea about like thinking of the strategies. So having a third party to help. I think even maybe for some of our loved ones, communicating with words is challenging, but
Mhm.
sometimes writing can
Yes.
be a way where you can communicate more. But I loved it that you mentioned someone who we both admire, Dr. Paul Rea, and his communication suggestion about removing the no's, right? And saying yes, but first, yes, and I think that Dr. Rea also is wonderful at just always talking about feelings first.
Yes.
And I think that that really goes along with what you just were talking about, the we perspective,
Yes.
and really thinking about where is this behavior, like increased interest or lack of interest? How is it related to feelings?
Right. Right. And I think this is so important because the issue of belonging to a relationship is so key. And I think when you're dealing with a disease like this, it can be really difficult because your relationship is changing. Your role in the relationship is changing. And the person with dementia feels that as much as the care partner feels that. And so, in some ways, I think people with dementia are interested in making sure they still have that feeling of belonging to the relationship and the feeling of connectedness. And so, sometimes the way that a person is seeking out that feeling of belonging or connectedness is through sexual activity, because that may have been the way you expressed your connectivity to each other in the past. And if you're less comfortable with it, remembering that the feeling of belonging and connectedness is the key. And so when you say feelings first, exactly, how can you feed that feeling of belonging and connectedness, even if it doesn't include sexual activity? What ways can you be creative about expressing that and making your partner feel like they belong to the relationship? And maybe it's through other aspects. We talked about spiritual and psychological. We talked about your commitment to each other, your shared values. And maybe it's other intimate activities that aren't sexual but are just special to the two of you. And I think those are really key aspects to feeding that emotion that the person with the disease has, but also for the care partner who may be feeling a real loss of the more intellectual connection with someone they have had in the past.
Well, and we know that the nature of adult intimate relationships is incredibly complex. And, you mentioning that this maybe a loss of an intellectual connection or a loss at the same level that it used to be, right, can impact your feelings about other aspects of your relationships.
Absolutely.
Yeah.
Right. Relationships are complex for sure.
uh, all kinds of relationships. And I think what I really love about the case study that you presented is this idea that even that after a diagnosis of dementia, after moving into an assisted living or a memory care community, you could have new relationships,
Yes.
new experiences of love and connection in your life. And I think that it is not something widely discussed about this area of need for individuals living with cognitive impairment.
Yeah. I think you're right. And it's missed, right? We think a lot in community settings about safety and about health and about all these other aspects of the care plan. We even think about people's spiritual needs and their social needs and all this stuff, but it's not a discussion about emotional connectedness. And sometimes we're in fact discouraging residents from having touch with each other. Particularly in the last year and a half, I think of all the people who have suffered from that lack of just human touch due to the virus. So I think it is really important that this becomes part of the care plan and becomes part of what we talk about with community providers for everyone, not just for those that are expressing the desire to have this, but for all residents, um, and for people living at home as well. It needs to be a conversation that is part of a care plan and part of thinking about that person and who they are and what their needs are.
Because this is talking about humanity, and it's talking about the whole person. Uh, I think that that is something that we work very hard to do in our clinical practice in the MGH FTD unit, but it can be something that you need to learn over time. And especially we recognize for families, you didn't go to a PhD program or medical school to learn about dementia and progressive neurological disorders. This may be a totally new experience for you, and you need the guidance of your medical team to talk about and normalize these issues.
Yeah. And I think medical providers are more prepared now than they ever have been to have these discussions. So I would encourage you to have them. And if you're finding that your provider is uncomfortable with having the conversation, you might need a new provider because this is something that should be part of the discussion.
Right? Yeah. We had a kind of a specific question about, I think, mechanics and pleasure and changes that may come along with sensation. I,
Yes.
I think you answered a little bit of it by
Hmm.
talking about thinking about other ways to make those intimate connections. But do you
Right.
have anything in addition to add? Um, I think the question's really about what happens when things are different.
Yeah. And I will say that these changes can happen with aging. These changes can happen because of the illness. Or these changes can happen because of a lack of attention, being able to focus on the activity for a period of time. And these are certainly things that clients of mine have experienced. I think the key is patience and flexibility. That the way that you've engaged in things before may need to be different now. That even the kind of stimulation or the kind of activity that you're doing may need to change. Even if it remains a sexual behavior, it may need to change into something that you both feel comfortable with. And it can be really upsetting if sexual dysfunction is part of the conversation, and very embarrassing for the person that is experiencing it. And I do have one couple that I work with where literally the sensation is not there anymore. And it goes along with some of that biofeedback that we see get disrupted for some people with some kinds of dementia in other areas. The feeling of hot and cold, the feeling of pain, the feeling of need to void, right? These are all things that can get disrupted between the nerve endings and the brain. So it's not surprising that this is another one that comes along. I would be very careful and have a lot of conversations with my medical provider if I were looking for a pharmaceutical intervention here, because we really want to be careful about those things. Um, but I do think that flexibility and patience and being able to think about things differently is the key.
And you know what? That's the key even outside the bedroom when we're talking about navigating life with a diagnosis. So I think another message that we hope folks will take away today is that the concepts that you're applying to be flexible, to learn how to do things in a new way, they transfer to this intimate experience and connection as well. Feelings first, taking things slow, getting support when you need it are all critically important. I appreciated that you acknowledged that grief and loss can be a real element here with changing relationships, and even some of it is an assault on your personhood.
Yeah.
So I just wanted to validate that this is an experience where many couples and individuals have expressed loss and sadness, and that it is valid to reach out for support in that domain.
Not just valid, essential. So, I think people who, and I'm one of them, by the way, I'm a family member as well as, this being my professional passion. And I will tell you that it is so important. This is a unique grief experience because you're experiencing the loss that is right in front of you, but you're also experiencing what we call anticipatory grief, right? What is going to happen as this progresses? And how much more am I going to lose? What is the timeline here? And so it just creates an unbelievable amount of fear and worry and disappointment for the picture you had in your mind of what the rest of your life was going to look like with your partner. And so I think absolutely reaching out to have someone help you process those feelings of grief is vitally important to your well being, whether you're the person with the disease or the care partner. It is really important. And I know there are people out there that I refer to that are specialists that work with you in counseling to work through these issues. There are also lots of people like me who are care managers that help families work through these grief processes. And so there are lots of resources, there's support groups, there's all kinds of resources for you to work through these things. And it's vitally important for you to be present in your relationship and being able to be part of your relationship going forward with a person who has these kind of illness, for you to be dealing with those grief feelings on your own as well as together with the person who has the illness
As the we, right?
as the we, right?
You just answered that question so beautifully, thinking about the dyad, the couple. And I would love to also have you help me respond to it in the way of thinking about working with families. So you started your presentation today saying, if someone had told me that I would be talking about intimacy and sexuality in my career, I would say, probably not.
Right.
Thinking about, there are many caregivers, care partners that are adult children caring
Yes.
for a parent. And it may be a brand new element in their relationship that they're talking about sexuality with their parent for the very first time.
Right.
And so maybe if you could speak a little bit as we're closing out our time today about the types of supports available if this is a new territory for you as a care partner or caregiver.
Yeah, it's a great thing to mention. And again, I think a lot of the same supports apply whether you're an adult child or a spouse. But I certainly have had lots of adult children that have been very uncomfortable with this kind of a discussion, especially if they grew up with a parent who largely did not discuss these issues, right? And then all of a sudden are discussing them, or talking about their needs in this area, and it makes the adult child very uncomfortable. I think there are people like me, there are people like Katie, there are counselors out there that can help you do two things. One is work through your own discomfort and your own feelings about it, but also the strategy for talking through these things with your parent and trying to figure out where do you appropriately redirect that conversation if you really are so uncomfortable that you feel you can't participate in it, because the conversation needs to happen with someone if the person is exploring this or expressing a desire or need. And so we need to have that need met. That's really important. But if you as an adult child are saying, I just can't do that, that's okay. But let's figure out where that discussion and where that processing of those feelings can take place for the person with the illness. And then how do you get the support if you do want to continue to be part of the discussion? What's the strategy for approaching these conversations? Because your instinct is to shut it down or avoid it or become really uncomfortable yourself. And there are specific ways of having this conversation depending on what's being expressed. I think uh, there's something my mother told me a long time ago about parenting that applies here, which is only answer the question that's asked. So sometimes I think we have, the instinct that when someone starts to talk about something that's uncomfortable, to start talking a lot and, well, what are you talking about, and asking a lot of questions. And so I think one just basic strategy is to just address what's being said in that moment without adding additional context to it, and to remember about feelings first, and remember that that's what's being expressed is the feeling, the want, the desire for the connectedness with another human being. And so gearing the conversation toward that will help get over the awkwardness of the topic at hand.
And I think that you presented it so beautifully when you were using the case example of the community providers and this idea of two families, two individuals living with a diagnosis, the care team. And just thinking of that visual image, I can see a lot of places for support within that. I think that is the take home message, is that support is available to you. And it's a topic that providers hope to engage with you about when the issue presents itself so that they can feel like you're part of the conversation.
That's right.
Well, we had a lovely message from one of our attendees today. Love is patient, Love is kind. You are love. What a beautiful sentiment, I think, to leave our listeners with today, and to really, I think, emphasize the focus of our entire presentation, which is about connection and caring.
Thank you so much, Katie. And this was a great discussion after the fact. So thank you.
This session will be it's been recorded, and it will be posted on our MGH FTD YouTube channel. Any additional resources will be included in the description for the video on our YouTube channel. I want to thank everyone for listening today. The Massachusetts General Hospital Frontotemporal Disorders Unit is a clinical research program dedicated to providing the highest quality of care while we work tirelessly towards a cure for frontotemporal dementia, Alzheimer's disease, and related disorders. Thank you for being a part of this webinar, for being connected with our community. Be safe and well.